Good evening, everyone. I hope everyone is doing well. We are going to get started with our Starting Out Strong webinar. My name's Lori Watkin, and I am responsible for community outreach for Theraplay. We also have Lauren Toolin here, who is making sure that everything is running smoothly for us, so we appreciate that. But I wanted to introduce to you our panelists that are going to be presenting information to you tonight, and encourage you, if you have any questions, to please send them in, and we will handle them as they come. So first I'd like to, I'll start with the middle picture. We have Jenna Reeder, who is the Associate Director of Outpatient Services at Positive Steps Therapy, as well as an outpatient and early intervention physical therapist. She's been with Positive Steps Therapy since 2010, and since then she has led the growth of Positive Steps in the Butler Center as their facility director until taking the role of associate director. Jenna's education came from Gannon University and the University of Pittsburgh. She has certification as a credentialed clinical instructor by the APTA and continued education in torticollis, cerebral palsy, and autism in early intervention, along with training in plagiocephaly and R&D. And for those of you that don't know what torticollis and plagiocephaly are, you will know that at the end of this webinar. She enjoys being a community partner in local events, including Kids Day America and Week of the Young Child. Outside of work, Jenna enjoys skiing, bowling, spending time with her twin 6-year-old sons, and following college basketball with her family. All of this, of course, is pre-pandemic, especially Pitt. Jenna became a therapist because it enabled her to watch someone learn something new every day. She feels that kids have an amazing, powerful, and positive attitude about life. And as I'm quoting her, she says, "They never cease to amaze me. Their willingness to do anything and everything they set their minds to." So as you can imagine, Jen is from the western side of Pennsylvania. So then I'm going to move over to Colette, and she is the founder and executive director of the Breastfeeding Resource Center. She became an international board certified lactation consultant in 1998 and opened the Breastfeeding Resource Center, as we'll refer to as BRC, in 2003. Since then, Colette has led the growth from one small outpatient center to 2 large centers, as well as being contracted by 2 local hospitals to provide breastfeeding services. She's developed free support groups and low-cost classes. She also developed a robust internship program for aspiring lactation consultants. Colette was a recipient of the 2017 USLCA Award of Excellence. She's the 3rd person in history to win this coveted honor. We're really excited to have her on this webinar as well. When not working, Colette enjoys walking, gardening, and playing with her granddaughter. Then last but not least, on our right side of the screen is Irene, and she is the center manager at Theraplay in East Norton. So Colette and Irene are from the eastern side of the state, as well as an outpatient speech language feeding therapist. She became a certified lactation counselor in 2017 and has specialized in pediatric feeding assessment and therapy throughout her 18-year career. She's been with Theraplay since 2009. Irene has developed and taught master's level coursework and has served as a clinical educator and supervisor for graduate students and has mentored many speech pathologists through their clinical fellowship years. In addition to treating feeding difficulties, Irene has expertise in treating early language disorders, apraxia of speech, and autism. She enjoys that her job allows her to collaborate directly with families and a team of professionals, and she also has 3 young children at home. So we're very excited to be able to bring this panel of experts to you tonight. We have had several requests from especially pediatricians to provide education to new parents during this pandemic. So we're hoping that you'll find this valuable. Feel free, ask questions, and we will take it from there.
Okay. So hello everyone. As Lori mentioned, my name is Jenna, and I thank you again for joining us tonight. I am the Associate Director of Outpatient Services at Positive Steps Therapy, but I am also a physical therapist, and I have the wonderful and great pleasure of treating children, especially from birth up to the age of adolescence. And my favorite thing about that is the opportunity to coach families and children to be able to restore and maintain their health and their function through a variety of ways. So when I meet a lot of families and spend time with parents and caregivers, especially in the first year of life, they'll often ask me, when should I expect my kiddo to be able to do X, Y, and Z? And so as we're going to go through here at the beginning are the milestones and things that you may anticipate to see a kiddo and an infant do in the first 6 months of life. We often refer to those learned tasks as milestones, so that's how we're noting them here. And do consider that kids, there are ranges of ages that we anticipate that children will meet those milestones. So not everyone meets them at the exact same time. So you'll see here during the first 3 months, we expect that kids will be able and infants will be able to turn their heads, and they're going to be able to look towards sounds and voices. They're really at this time exploring the world around them and trying to have their needs met. So they'll turn their heads to the right and the left sides, and the muscles in their head and neck are still gaining strength. So they'll need some help to control their head, and you may need to hold their heads while you're holding them upright, but they should be able to, like I said, go to the right and the left side both equally. And when you're placing them on their tummies at this age, you'll see that they should also be able to do the same thing. So, you put them on their tummy on the floor or on your chest, and they should be able to turn it to the right and turn it to the left. At this time, their muscles are not too stiff, but they're also not too floppy. So you'll see that their legs may be curled up a little bit from being tucked in that small place for some time before they were born, and their arms held a little closer to their bodies. And they're beginning to learn to transition to different positions. So they may begin to roll to their sides from lying on their back. And this may happen just spontaneously as they're, stretching themselves out to have their diaper changed, or just laying on the floor and watching what's going on around them in the room. Their vision is also really developing at this age as well, so they'll begin to be able to look at faces and track people and toys as they're moving around the room. Their hands are also relaxed and open at this point in time. So you should see, if you put your hand in their hand, they may start to grab your hand and hold your hand. And when you let go, their hands are, at this point starting to open up and relax and not become closed-fisted all the time. And that vision is going to be important as it's rapidly developing so that they're able to explore the room around them. And as they do that, then they'll want to become more mobile. So it'll help them to have an awareness to want to reach and want to roll so they can get to people and toys around them. And then as we move to the 3 to 6 months, an infant and baby's movements start to become more purposeful. So they're, as I had said, they have more awareness, their vision develops, and so some of the things they're doing become more purposeful in nature. They're continue to turn their head and their neck to both sides. So, they're going to look to see where a voice is coming from, or a sound of a toy, or hearing someone can come in and out of the room. And they should be able to do this when they're lying on their back and on their belly. And even when you're holding them upright, they should, start to be able to go to both sides. We'll talk about this a little more and why that's so important at this age, and how that's related to things that we call torticollis. And their reaching too also becomes more purposeful. So you should see them, bringing their hand up, batting at toys, and starting to reach and pull at them, using their right and left hands to do that. They might grab at your hair if you're holding them, or your face, to really start to explore what's around them. They might reach for toys that are hanging from a mobile near them, or activity toys that are nearby. And then also when they're eating, they may bring their hands up to the bottle, putting them on the bottle to help support as someone else is holding it and supporting it for them. And tummy time at this age is also very important. And when they're on their tummy, you may see that they're holding their head up high enough so that they can look around the room, compared to that 0 to 3 months when they're on their tummies and they're just barely able to kind of turn their head from side to side. Right now at this age, they should have their head up nice and high and be looking around the room at what's near them. And they may begin to push through their hands and their elbows as well to help hold themselves up. Their mobility continues at this age to become more purposeful as well. So sometimes you'll see that an infant will roll from their belly to their back, and that might come first, especially if they're enjoying tummy time and they're spending a lot of time on their tummy. They may learn to do that first, but they may roll from their back to their belly first. And when you're seeing them roll, we really want to look at this age too, that they're rolling to their right side and to their left side, and they don't have a preference to go to one or the other. They're both the same. So we'll move on to talk about torticollis. And infants are commonly present with this, and it is tightness in a neck and a specific muscle, as you can see here, called the sternocleidomastoid muscle. And what that muscle does is it tilts the head in one direction and it turns the head to the opposite direction. So if you look at the picture, this baby has one ear that's closer to its shoulder than the other ear on the other side. And then on the opposite side, their chin is turned away from the middle of their body, and it's closer to the shoulder on the other side. And this is what torticollis commonly looks like. Their head's tilted to one side and turned to the other. And we name it for the side that the head tilts towards. That's the side and the muscle that is tight. So if a baby's head is tilted to the right, we would call it right-sided torticollis. And the treatment for torticollis really can start right away, right at birth, if it's noticed and recognized right after birth. And it includes stretching the muscles that are tight and the sides that are tight, and strengthening the muscles that aren't being used. And this is something that can be followed along with a physical therapist to make sure that the stretches and the positioning of your hands are in the right place. And then the therapist also will follow along with their development of their milestones. So we want to ensure that as they're gaining strength and they're gaining motion and flexibility, that they're doing it to the right and the left side equally. So you can imagine this baby whose head is tilted to one side and turned to the other. It might be easier for them to use the hand that their head is turned towards and looking towards. It might be easier for them to roll towards that side, since the other side of their body is tight at this time. We look and make sure that, as I said, that they're reaching with both arms, they're rolling to both sides, they're using their arms and legs equally when they start to gain other milestones, including crawling and pulling to stand, as well as walking. And infants with torticollis are recommended to receive treatment by a pediatric physical therapist, as I said, and their goal there is really for the therapist to coach the family, coach you on the stretching and the strengthening and how to progress and look at their motor milestones over time. And this slide's going to show us a child with torticollis, and I'll show you first the, let's do the correct roll. So this is the way you may see a little one roll from their back to their belly. And we're really looking at his legs, and there they go over to the side, and lifts his head up nice and high off the floor as he rolls from one position to the next. So this kiddo has torticollis, and so let's look at the asymmetrical roll, and when he does it to the opposite direction, what that looks like. So he gets to his side, but oh, that head just keeps going and he can't quite pick it up. So that's what the importance there is of strengthening the side that is weak and stretching the side that is tight. So as he's developing these milestones and movements and transitions, that everything looks equal side to side and one side isn't getting stronger than the other. And it's important so it doesn't impede their development of mobility. We want them to be able to get to where they want to go and get to what they want to play with without having any limitations. I'm going to show you that really quickly again. So what this roll looks like for the kiddo that doesn't, or to the side that isn't affected. There goes the head, up and off the surface. And then let's do this one again. To the side that's weak and you can't quite get that head up. It's probably taken them a while to master that too, to try to get to that side. In most cases, when we see a child with torticollis, we may know how or have an idea of how the tortoise came about and be able to talk through the family about the birth history and positioning at home and their daily routine. And it helps us guide our treatment that way. And so let's look at this torticollis child that's creeping. And we call this the torticollis crawl. And you'll watch where she's putting her feet and her knees on the floor. And that left knee doesn't always go down, and the left foot goes up on the floor instead of staying down.
Exactly what I was saying.
Commonly seen in a child that's had torticollis. And again, that develops over time with the weakness on one side and the tightness on the other. And the therapist really helps to coach the family on how can we strengthen those muscles so it looks equal side to side. And this is the video on how the therapist is going to intervene and help this kiddo gain strength. So we're using a surface that's not even and unsteady for her to challenge for balance and have to use more strength to get up and over an obstacle. You see she's having trouble when she's using that one arm and one leg is down, kind of collapses. Like I said, kids are resilient, so we want that toy. We're going to do whatever we can to get there and get it. And she works so hard. And the therapist is just really figuring out, where am I going to put my hands to help her? So as she's moving, we're working on that strength that she has difficulty with evenly on the other side. And she finally gets the toy. So starting to talk about, how does torticollis happen? What is going on that creates this? And in some cases, just talking to the family to kind of have an idea of what's happened in their birth history. what's going on in their daily routine, how we're positioning at home, really helps to understand and coach through some things that can make little changes but can make a lot of impact. So torticollis really has a high prevalence among infants, and it's been on the rise with the number of kiddos that have it since the Back to Sleep program began. And we've also seen it as an influx of new baby equipment has been available to families. So we have all kinds of equipment that's kind of substituting what we normally would spend time maybe on the floor, tummy time and floor time. So things like the Mama-Roo and the rock to sleep and the Johnny jumpers. And we really want to make sure that instead of using those things for significant amount of time during the day, that we're placing our infants on the floor, getting our babies on the floor as much as they can, as well as doing tummy time. So you'll see, it can really be just from positioning before birth. So, maybe they were in the same position for a long period of time, especially during the last part of the pregnancy, and so the muscles become tight before they're even born. We'll see it sometimes in babies that have spent some time in the NICU, and that's usually related to positioning that they maybe needed to have just because of the equipment for the health of the baby. Like I had mentioned, the Back to Sleep campaign. Some families, don't always feel very comfortable putting their babies on their tummies. And, we'll go over that and maybe, and we'll discuss some different strategies and ways to do that throughout your day and your routine. And like I had also mentioned, the baby equipment. So a lot of those equipment put an infant and a baby in a reclined position. And at this age, that 0 to 6 months, they don't always have enough strength if they're put in a reclined position to move their heads and reposition their heads. And so they get stuck in one spot, and then that tightness and that weakness just starts to develop. It can also be part of the birthing process. Could include maybe an injury to an arm during delivery, and then along with that is injury to the side of the neck as well. And can torticollis affect anything else? So I have a list of things here I'll go over. So plagiocephaly really is referring to the misshapen or the misshaping of the back or the back side of the head from lying in the same position in the same spot of the head for a prolonged period of time. So at this point in a baby's life, the bones in their head are very flexible. So if the soft spots haven't closed, that doesn't come till close to a year old and sometimes later. And so the longer they're in one position, the easier it is for those bones to move and shift and start to create flatness in the area where the pressure is. There's a small degree of flatness that is normal, and then there are categories from there, from mild, moderate, and severe plagiocephaly, and therapists are able to measure that and determine and help families decide if additional treatment is needed or recommended, which could include a helmet, and typically starts with repositioning and coaching of the family. Also listed there is scoliosis. So since torticollis can develop changes in an infant's posture on one side of the body versus the other, it is possible to develop torticollis that's positional in nature. It can also begin to start to affect the craniofacial, so the eye, the cheek, the ear of the face, and how it's positioned compared to the other side. Gravity starts to pull, and tightness starts to affect the face and the facial features as well. Some of these kiddos, it's common that they may have been breached at birth and may also have some underlying hip impairments like hip dysplasia as well. So that's when the hips are not developing correctly and in the right position at birth. And then reflux and GERD. So that's one that's very commonly associated with torticollis, and they go along together very commonly. And reflux, is sometimes shown as, like, a parent will notice it as a result of their position. So a child that has reflux will begin to turn their head one way and tilt it the other way to open up their airway if they're having some discomfort from reflux. And so the reflux may come first and then the torticollis then secondary. And over time, that preference to become comfortable develops into habits and behaviors that progress into tightness and weakness in the neck.
Upper arm, kind of supporting that backbone in place, and then you want to stretch it all the way up.
So we're showing you stretching on the side that is tight and lifting the arms up and over the head and out to the side and up to the ear.
And stretching into shoulder abduction, and then shoulder external rotation.
Rotating and moving the arms outward to stretch the arms there as well. So the torticollis can also affect the range of motion and the strength in the arms as well. So if they're turning their head to one side, they may use that arm more, and the arm on the opposite side may begin to become tight. Other things on this list, BPI, so brachial plexus injury. So that's where you may see injury to the arm and the nerves that run through the shoulder area that could happen during the birthing process. Club foot, when the feet as the child is born are significantly tight. And then metatarsus adductus also includes tightness of the foot at birth. So tummy time is extremely important to begin right away, and definitely at this age from 0 to 6 months. It provides infants with the position they really need to gain the strength in their head and their neck. If you think about it, if you put them on their tummy, they really have to lift that head and neck up, and it gives them the opportunity to gain strength in those muscles. And it also provides them with a chance to learn to use their arms, using them to roll and beginning to prepare them to crawl. It's recommended to position an infant on their tummy at that 0 to 3 month age for about 5 to 10 minutes 4 times a day. It doesn't have to be structured and, okay, let's sit down and set a timer and we're going to do tummy time and set a timer for several times throughout the day. We'll talk about, you can include this in your routine and things that you're already doing. It is recommended that you're doing this time when the child is awake and supervised. And then as they gain strength and tolerate being on their tummy, the goal is really for them to stay on their tummy for 30 minutes, several times a day, so 2 to 3 times a day. It doesn't always go that easy. It's very common for a parent to come in, especially a parent of a child that has torticollis, and say, as soon as I lay this baby down, she's crying, and I have to pick her up right away. So we'll talk about some tummy time ideas here. So it doesn't always have to be laying on the floor flat. You could include tummy time as your baby laying on your chest as the parent is laying back and kind of face to the parent's chest. You could lay the baby over your lap. And you can do that in different ways so that, if they're at the age where they're starting to look around the room, that they can look and see what's going on around them instead of having their face down in the floor if you were to lay them on the floor that way. I've also recommended to some families, if it's tolerated, is, doing that when a child is burping. So, if that's a routine that's going okay and you aren't having any difficulties, they tolerate laying on that position over your lap during burping time, you know that they're going to eat several times a day, and so they're going to get that little bit of extra tummy time often and frequently throughout the day. Okay. So we'll look here. This is a 3-month-old during tummy time using a boppy pillow. And the boppy pillow can really be introduced at that younger age when they might need a little more help and a little more support. You see his arms are out in front and elbows are down, really able to lift that head up. And that's giving him support at his trunk so that he doesn't have to think as much about that and can really just focus on picking his head up. And here's another one. So this child is a little bit older. You can see his arms are out in front of him on his own compared to the other video where the therapist is really bringing those arms in and tucking those elbows down so that he can help support his head. And this older child is able to keep his arms out in front of him on his own, use them now to pivot around in a circle and explore, try to get to the toys that are near him. Some other things you can do when they're in this position is maybe include a mirror in front of them so they have their own reflection or themselves and someone else to look at when they're on their tummy. You can also use movement, so the tracking of the toy, and get yourself down on the floor with them. And that usually will be a good motivator to lengthen out that tummy time longer. And a few other ideas. So if you're using a mobile, if it's on an activity mat or in the crib or attached to the car seat, you might want to move it from the right side to the left side, each day a different side. So they're looking to both sides the same, have the same amount of opportunity. You might want to switch the car seat placement. So the same kind of idea. Maybe this week we're going on the right side of the car and the next week we're going on the other side of the car. Consider things that are in the room that they want to look at. If there's something that's visually motivating to them and they're very interested in, maybe consider where it's at and what side that the child has to turn their head to look to find it, and move it if you can. You may also want to think about the dressing and clothing that your kiddo is in. Make sure that it allows for freedom of movement, that they can move their arms and legs without really being limited, so that they can get to their sides and roll and reach in all directions if they're trying to explore and get to toys and play. Try to avoid using a car seat except for the time that they're really in the car. Give them the opportunity to be carried, to have floor time, that tummy time that's so important. And think about using a firm surface to sleep on from the beginning, during their naps and throughout the night, as early on as possible. This gives kids the chance to, as I had said, really pick up their heads and move side to side without gravity pulling on it in that inclined position that a lot of carriers have. Okay, so it looks like we're moving on here to the feeding milestones. I'm going to hand it over now.
Okay, hi everybody, I'm Colette. So the babies are born with many reflexes, and interestingly enough, those reflexes are designed to help your baby move to the feeding, latch on, suck, swallow, and get food. So many of the reflexes your pediatrician will be testing maybe in the hospital setting are those reflexes that help the baby feed. And they tell us that the baby is neurologically sound, and it does help your baby feed well. So if any of these things are inhibited by something else, that could affect the way the baby feeds. So the oral reflexes are rooting, that's sucking on their hands and fists, suckling, tongue motion, swallowing, and the gag reflex. So these are both used for both breast and bottle feeding. And they're very important to be able to enable the baby to feed well.
Colette, can I actually jump in on this slide?
Yes.
Okay, sorry. I'm going to do this one and the next one, and then I'm going to kick it over to you.
Okay.
Okay, thank you. So I want to talk a little bit more about about the different reflexes here. So as Colette said, they're important for both breastfeeding and for bottle feeding. And we also see infants, that might have some more difficulty with these reflexes, or they might be persisting longer than they should, which might indicate, something different going on that would need more medical intervention. But one of the things that you can do if you have a little infant at home now is try to elicit some of these reflexes. So that rooting reflex should really be present from birth. And that's when you're touching the baby's cheek or lip and they're turning their head back and forth to try to find the source. And that helps them to locate the breast or the bottle for feeding. And the baby can even elicit this reflex on their own. So if they're putting their hand up to their mouth, then they might start rooting back and forth to get their hand into their mouth as well. That suckling reflex you can also elicit on your own. So if you wanted to place your finger inside your baby's mouth, you would actually feel the tongue kind of wrapping around the finger and that movement back and forth, which helps to get the milk out of the bottle or the breast. This is kind of a motion that changes as the baby gets a little bit older. It's really important, particularly for establishing that initial, full suck on the breast and bottle. For the tongue, for this reflex, if you touch your baby's lips or tongue, you'll feel that same like front and back movement of the tongue. But as the babies get older, like around a year, that's a reflex that fades out too. And then that swallowing reflex would just be when something enters, excuse me, when something's entering the back of the mouth, they're having that reflex to swallow the liquid. It's something that was really important for safety initially. We want those babies to be swallowing in a very timely way, in a very rhythmic way, so that they're safe. And then our gag reflex stays with us throughout our lifetime. It's very protective, but it does change. So in those first few months, that reflex is stimulated closer to the front of the mouth, and then as the baby gets a little bit older, it moves back. And as Colette said too, like all of these reflexes are important for breast and bottle feeding. And at this age too, we're starting to see the hands go up to the mouth, and the baby might be sucking on their hands or their fingers too. I don't know if I have control here. Let's see.
You should be good, Irene.
Let's see. There we go. Awesome. All right, so then moving up to 3 to 6 months, we're seeing that suck, swallow, breathe pattern improving, and we're seeing our babies even do sequences of 20 or more sucks without a pause while they're feeding. They really get excited when they see the bottle or the breast as well. They're anticipating that feeding. So around that 3-month mark is when these feeding skills really transition from something that's reflexive to something that's within the baby's control. So as a speech therapist, this is a time when I get a lot of referrals right around that 3 to 4 month mark, because babies are coming out of that reflexive stage. And as they enter that stage where they have to really control these movements on their own, they might be struggling. And it might be due to something like low muscle tone. There might be some neurological differences. They also might have had, some different things happen in utero. They might have been a little early, those types of things. So it's something that if you're noticing these difficulties, your physician will probably refer you out to, a lactation consultant, or they might refer you out to a speech pathologist or even an occupational therapist sometimes to help. But at this point too, in development, we're kind of seeing all of those parts of the mouth separate and differentiate movements. So in the beginning, everything's kind of moving as a unit within the mouth. But at this point, we're starting to see the lips, the tongue, and the jaw separate movements. And that's really important for feeding development and also for speech development. So at this point, we start to hear some of those really fun sounds. Dads always win because that dada tends to come out first. So we'll hear that dada, we might hear the baba sounds, whereas up to this point, we were really hearing more of those vowel sounds or those throaty sounds. Looking at this stage 2, we're seeing the baby more active during feedings. They might be patting at the breast or patting at the bottle, even trying to hold on to the bottle themselves too. And as I mentioned on the previous slide, that gag reflex is changing in the first year. So at this point, it starts to move back a little bit further in the mouth, which is prepping them for some solid foods as well. So depending on your pediatrician recommendations and the method the method you're currently feeding your baby, because it varies between breast and bottle fed babies, you typically be introducing solids in that 4 to 6 month range. And then we're also looking to introduce cup drinking around 6 months as well, because that's, again, is that point where the movements are really being separated out. Let's see. At this point too, I wanted to mention, we really shouldn't see any coughing or choking during feeding. And if it occurs, it should be very rare. Another thing that would kind of be a red flag that something might be going on is if we're seeing any excessive drooling at this point, we really shouldn't see any drooling in infants unless they are teething. So if they are having some drooling, that would be something that you would want to bring up to your pediatrician as well. And I'm going to kick it right back to Colette for the next one.
Sorry, I didn't mean to jump in.
All good.
So this slide, the benefits of breastfeeding, there are plenty of benefits, far more than are listed on the slide, but some of the highlights here for baby, breastfeeding doesn't only boost your baby's immune system while they're feeding, but it helps to develop the immune system for lifelong health. So in the initial time period when you're nursing, you're going to have fewer ear infections, respiratory infections, diarrheal infections. But long term, you'll have less obesity. We have decreased diabetes. We have, decreased risk of childhood cancers, like craziness, the positive impact when you start out breastfeeding. There's also better mouth development, so less risk of braces, which cost a fortune, by the way. But it's the soft breast tissue in the baby's mouth instead of the hard plastic that helps to develop the mouth. And the tongue motion is far different with breastfeeding than bottle feeding. They don't need to use it quite as accurately, and therefore they have a better development of that later. Improved suck, swallow, and breathe synchronicity. So that's the flow of the milk is far different with bottle feeding than with breastfeeding. So we are a bottle feeding culture, and so we're accustomed to seeing babies bottle feed, but it looks very different at the breast. So you'll see a baby do a suck, swallow, breathe pattern in a very rhythmic fashion, which allows them to breathe. Where with the bottle, they tend to have to feed more quickly, and the suck and swallow is very quick, and sometimes they can't manage the breathe part. So, babies that have low tone or maybe premature, they have an easier time at the breast handling the milk flow. There's also less constipation and reflux with breastfeeding. The milk is designed for humans. So each mammal has a certain milk that's designed for their babies. The mother whale has a milk that's loaded with fat, so they can grow very quickly and swim in freezing cold waters. And our milk is designed for brain development and neurological development. There are also tons of benefits for moms. So there's a bond, because the prolactin and oxytocin, which are the mothering hormones that create milk and send milk to your baby, those are coursing through your body throughout the day. So those are the hormones that make you look at your child and go, oh my gosh, this is the most beautiful child I've ever seen. Even if the child is not that cute, it's those hormones coursing through your body that help you feel that way. So we see that breastfeeding reduces the amount of child abuse just because of those hormones going through mom's body. It's also very convenient. It's readily available. It's always the right temperature. There's plenty of milk there for the baby. There's not a lot of waste because the baby comes off when they're full. And it comes in some very attractive containers too. So it's very convenient. Some of the other benefits for mom is that when she's nursing in the early days, first 2 to 3 days, she's going to feel some uterine cramping if the baby's feeding well. And the hormone that releases the milk, which is oxytocin, also contracts the uterus. So it helps you get your uterus back to its normal size more quickly, which also reduces your risk of postpartum hemorrhage. So there's some very good positives. It's a whole system. You're feeding the baby's helping your uterus get back to its normal size. I mean, we're designed in a very interesting way. The other health benefits for you, it can reduce your risk of breast cancer, ovarian cancer, heart disease, osteoporosis. The benefits are endless. It's because you're using the body the way it's intended. And no one can deny that it saves money and that it's green. You don't have to purchase anything, and we don't have to go to milk the cows, send the milk to the factories to make the formula, have the formula sent to the grocery stores, and have you go drive to pick it up. And there tends to be a lot more waste because you make it by ounces instead of by need. So lots of benefits of breastfeeding for both mom and baby. So what are some of the breastfeeding facts? You know, if it hurts, it's not right. And too often, I've been working with mothers for well over 20 years, both in the hospital setting and in the outpatient. And too often I hear, well, it hurts like crazy, but everyone tells me the latch is right. But that is completely untrue. If it's painful, something's wrong with the latch. It could be something very easy to fix, like, you know, changing the baby's position or moving them a little bit to the right, a little bit to the left, have mom do this, do that, and we can fix the latch. And sometimes it's more anatomical, something going on in the baby's mouth where we have to either alter the position or actually figure out why the mouth is angled a certain way or the tongue is moving a certain way that is causing pain. Demand makes supply. So this is the biggest, I feel like, mystery, is that people wait for their milk to come in. So initially we have colostrum, which is the low volume milk in the first couple of days. It's low in volume, but it's packed with nutrients. Babies don't need a lot of milk in the first couple of days, but they do like to suck. So they like to hang out there for periods of time, but they don't need ounces. They need small volumes, like a teaspoon of milk. I equate it to drinking your coffee out of your stirring straw. That's how long it takes them to get the whole meal in. And so it could take some time, and that's why we're designed that way with this thick, sticky milk. And the way it works is that as often as the baby takes out milk, the body replenishes and it tells the body to make more. So it's the draining of the breast that encourages production. So when people are waiting for their milk to come in, that's not how it works. You have to tell the body to make milk. So when people are suffering from low supply, typically it's from the breast not being emptied frequently enough. And that may be either a management thing, either family is taking over to feed the baby to let mom rest, or it might be the baby problem where the baby's having a difficulty getting the milk out, so we're not sending the right messages to mom. So early unrestricted and unscheduled breastfeeding is really the best thing. And I think before we have our babies, we are like, oh, we're going to be in control. This baby's not going to rule our lives. Right? Those of you who have newborn babies, you'll know that they pretty much take control over the house. And that's that way for a reason. So in all mammalian groups, the baby runs the feeding. The mother cat doesn't call out to her kittens to bring them over to feed. They scream and holler at her when it's time to feed. And we need to follow that type of pattern because that's what leads to successful feeding. So it's feeding on demand. Pacifiers can help preterm infants or infants on feeding tubes transfer to the breast. If your baby's a preterm infant and separated from you, yes, we use pacifiers. You're not there. you know, one of the biggest statements I always hear, don't let your baby use you as a pacifier. And I'm like, why not? What is the worst thing that can happen if the baby's nursing and getting comforted from their mother? But when you're separated from your baby or you're having difficulty breastfeeding, sometimes they'll need those, the pacifiers, because they love to suck. And it's really important to keep in mind that a newborn baby feeds 8 to 12 times a day. And people say 8 to 12 times, okay, every 2 to 3 hours. Well, here's the news. You gave birth to a human, not a robot. So they don't feed specifically every 2 to 3 hours. You may have times that a baby will feed every hour for a 3-hour time period and then sleep for 3. So it varies greatly throughout the day, and you need to wave the white flag and surrender and allow the baby to lead the way to manage the milk production, because truly they're the only ones who know how much milk was available, how much milk they took in, and when they need the next feeding. Obviously, in rare cases, there are sleepy babies that maybe need to encourage to eat, but in most cases, healthy full-term babies will let you know when they're ready. So what happens in the baby's mouth? Like I mentioned earlier, they are born with these reflexes. And so in many hospital settings and in all birth center settings, we are putting babies skin to skin after delivery. And we call it the magical hour, the hour after birth, where a baby will lay skin to skin with mom. And during that hour, all of their reflexes come to life. So they start to crawl, they start to do the finger grasp, they grasp onto the breast, they pull themselves up, they root and look for the breast, and they latch and they suck and they swallow. So those reflexes are there for a reason. It's help the baby to eat. The tongue helps the baby to suckle, and tongue motion is really important in breastfeeding. The tongue needs to move in a peristaltic motion in order to strip the breast of milk. So anything that might inhibit that motion could cause problems with feeding. And swallowing moves saliva, food, and liquid towards the baby's stomach. So that's a typical reflex in the baby's mouth to give them that ability to swallow well. So if you're seeing swallowing issues early, you might need to address them to help the baby with solid foods later. Bite works important jaw muscles that are needed to close mouth, take bites, and jaw motions for speech. And so very few of us, it's rare, but some mothers are experiencing this bite happening before the baby's ready for solid foods. So babies can clench down at times, and it's a reflex that may be starting a little earlier than you'd like. If that happens, I encourage mothers to break the suction, take the baby off, end the feeding, and give them time before you introduce the breast again. A lot of times babies will do biting before the introduction of solid foods, and while they're at the breast, they typically do it at the end of the feeding where they're no longer feeding. So that's a tip to take home. If you have a biting baby, you just cut them off because it's probably the end of the feeding. The gag reflex protects babies from swallowing items that are too large. And some babies have an overactive gag reflex, which we can work with in the early days when they're breastfeeding. But later, you know, during solid foods, if you see an overactive gag reflex, most people are scared. They think the baby is choking, but it's a reflex in there to protect them. And so when they're gagging, they're trying to push the milk or food forward so they don't choke. I think I've lost my ability to switch slides. Oh, there it is.
Got it?
Okay, sorry about that. Signs of a good latch for feeding. So there's a lot of things I look for when I'm watching a baby feed. I want the big, wide open mouth and flanged lips. So if the baby is using their tongue appropriately, a lot of other things I can see are happening. So their lips should be flanged like fishy lips, and their cheeks should be rounded. And that tells me that their tongue is appropriately placed and doing the right thing. They do a small jaw movement in the beginning once they're latched. And as they do those small jaw movements or quick ones, that initiates the milk flow. And then you'll see a more constant suck and swallow over and over, which occurs during the letdown reflex when the milk flow shoots out a little more quickly. And then you want to see the baby going to a more rhythmic feeding. So maybe, suck, 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 swallow, rest. Suck, 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 swallow, rest. As long as they're rhythmic, that really tells me that they're transferring milk well. The tongue motion should be wave-like. I told you, like a peristaltic motion. It's not something you can see from the outside, but if that's not happening, you may hear a clicking or some other kind of noise that tells us that the tongue isn't moving correctly. And then you want, positive pressure to pull the milk out. When the baby comes off the breast, we want to see that the nipple is a normal shape. If it's creased, compressed, or angled a certain way, that tells me that the baby wasn't latched correctly. We also don't want it blanched from cutting off the flow to the tip of the nipple. That would be another sign that things aren't good. And sometimes when I'm watching a baby feed, I'll pull down on the chin and the lip comes down, and I want to see that the tongue is right there, and that's a good sign the baby's got the tongue motion going in the right direction. So feeding struggles. So maintaining a latch. If a baby latches and keeps sliding off, in that case, that would tell me that their tongue's not doing their job. So I would give a thorough look through at the palate shape, the baby's ability to extend their tongue, the baby's ability to hold my finger in their mouth, so their tongue should cup my finger. And then I would look at the suction. It's how strong they're pulling. So all of that can tell me that the baby's tongue has the ability to do all the things that they need to do. Sometimes if they do have a tongue tie, they may be able to get their tongue in the right place, but they may not be able to keep it there for long if there's a muscle that's pulling and making it harder for them to keep it extended or rounded appropriately. Some other feeding struggles we see in the early days is the milk flow. So the Goldilocks effect is milk flows too fast, the milk flows too slow, and we want it just right. So a milk flow that's too fast, you'll see a variety of things. Some kids will just gulp it down and they're just guzzling the milk, and they may spit it up later or maybe not. And some will like come off and let it spray all over the place and then go back down go back on when the milk flow slows. Some will just let it pool out the sides of their mouths if it's too fast. So there's different coping mechanisms for a fast flow for a newborn baby. For a slow flow, if that's all they know, they're fine with it. If, let's say, mom's flow is slower and the baby starts taking more bottles and that flow is very quick, they may decide they like a preference for the faster flow. But there's ways around that. So if they prefer the faster flow, we can do something called paced bottle feeding, which slows the feeding down, and other tips for bottle feeding so it's not so fast. Sometimes it's as simple as changing the baby's position so that they're more comfortable handling the flow, especially if it's fast. Problems like reflux, we should say problems associated with reflux, because the problem is more GERD. A lot of babies have reflux. I see them, pulling up milk in their throat and making faces and swallowing it down, but it's not impacting the feeding. So when the reflux episodes impact the feeding and it looks like the baby's in pain or they're struggling to gain weight, that's when we're going to make our move to talk to the pediatrician about possibly a medication. But what babies can do if they're breastfeeding and they have reflux or problems associated with it, they behave in a way where they latch on, I'm really hungry, and then they pull off like, oh my gosh, this hurts. And then they latch on and they pull off. So they do this bobbing off and on the breast with crying and arching their back. And sometimes babies will go to the breast and feed, but it's uncomfortable to get a full feeding. So when their tummy starts to get full, they'll come off and they'll be like, well, I'm not taking any more in. And weeks down the line, you may see a decrease in weight gain and you may see mom's supply drop quite a bit because they self-manage by taking in smaller volumes of milk at each feeding. So if you see some of the signs of GERD, then having the baby medicated can help with the feeding process. And there are some babies, they do great at the breast, but don't bottle feed well. And then you have some babies who do fine with the bottle, but don't breastfeed well. And then you have a certain number of babies who can't do either very well. So there's a wide variety of how GERD looks like in feeding babies. Colic. So as we know, or maybe we don't, the definition of colic, we don't even know the definition of colic. This is a baby who is miserable and crying for periods of time every day, and no one quite knows what the reason is. But I think every family who's had a colicky baby knows that it seems like it's stomach issues. And if that's the case, I would typically look at the weight gain and how much they take at the breast and what they look like while they're feeding to determine if they're getting maybe more air than they should, maybe they're not getting enough milk, maybe they're getting too much and they have a tummy ache. But there's a variety of things we can do to help the colicky babies to figure out what's going on. With torticollis, that preference to a certain side goes along with feeding, not just, looking for toys. So if we need to find a position that the baby's comfortable in. So sometimes if a baby has torticollis, the mother might be using the football position on one side and the cradle position on the other because the baby just prefers to be lying on one side over the other. But continued work with a physical therapist, doing the tummy time, and maybe encouraging the baby to use other positions can help with stretching those muscles out. And the tongue tie we talked about a little bit. There are anterior tongue ties. That's when the piece of skin under your tongue is very close to the tip of your tongue, and that would inhibit you from pulling your tongue out past the gum line. These babies may look like they have a notch at the tip of their tongue. It may look heart-shaped. And when they push their tongue out, they may have an indented line down the middle of their tongue. If it's farther back, which we call a posterior tongue tie, you'll hear these babies clicking at the breast. You may see a white coating on their tongue. So these babies can't lift their tongue and allow it to be cleaned by the roof of the mouth. So you might see a thick white coating that they can't get rid of. And they may have difficulty swallowing. So if you talk to some pediatric dentists who are well versed in tongue tie, you'll see the majority of babies who have tongue tie, the biggest problem is breastfeeding. A portion of those kids might have trouble swallowing solid foods, and a portion of those may have problems with speech. But it truly does impact breastfeeding, and that's been a change over the past 15 years or so in the realization. I mean, we went from a predominantly breastfeeding culture to predominantly bottle feeding. And a tongue tie may not inhibit a baby from bottle feeding well, but it could lead to difficulties with breastfeeding. I think we were going to do this one together. Who's doing this with me?
That's me. So I feel like some of this is overlap too from the previous slide as well. So some of these things are similar and indicative of some of the things mentioned too. So like the vomiting and the chronic constipation and diarrhea can also be related to reflux, can also be related to maybe swallowing too much air, which might have some more of those colicky symptoms too. And in these cases, we're trying some modifications with positioning, with timing, and then also consulting with the pediatrician to see if there's any medications that might assist as well. Let's see, looking down here. So difficulty advancing to textures, chewing or latching onto the breast. So Colette, you actually talked about this a little bit with those babies that are getting that biting reflex a little bit early and their timing's off. So maybe clamping down on the breast a little bit. As far as advancing to textures, this comes a little bit later in development. So in that like 4 to 6 month range, if we're introducing solids, we're typically looking at more of that puree consistency. And then as we get beyond that 6 months, we might be increasing those textures. It all kind of depends on the parents' decision as well. So some moms and dads are leaning more towards baby-led weanings. They might be introducing some of those textured foods a little bit earlier. And sometimes that difficulty is just the baby letting you know that they're not quite ready for that food yet. But if that difficulty really persists, then you would want to chat with your pediatrician and see if a referral to another professional would be warranted. Lack of self-feeding, again, this is kind of a later milestone, but if your baby is hitting those older ages, and we're looking at that like 9 to 12 month mark, if they're starting that self-feeding at that point, they're reaching foods into their mouth or placing foods into their mouth. If we're not seeing that develop, you can also chat with your pediatrician about some referrals for that, or you can work on it at home as well and just encourage more hand to mouth in play and then also during feeding. Excessive mouth stuffing. So some of our babies that are low tone or low sensory might be placing too much in their mouth at a time. And this is something to just kind of chat again with your pediatrician about. And we can work on trying some foods that might give those kids, those babies, a little bit more input to decrease that wanting to stuff the mouth. Stressful meal times. This is probably the biggest thing that I hear on my end, is that mealtime isn't pleasant, and it can be for a number of reasons. But one of the biggest things that I always stress with families is if you as a parent are stressed during that feeding, if you as a breastfeeding mom are stressed during feeding, your baby will also be stressed. So we always need to be in check with our own emotions and what we're bringing to that meal, and make sure that it's the most positive energy, so then our babies and our kids can feed off of that. Let's see, choking, gagging, and retching. So these are definitely concerning things, but all of them kind of go down to the baby protecting themselves. So they're usually an indication that something is either not appropriate for them to have at that time, or they might be having difficulty with coordination. Snacks and snoozers. So we see these guys in breastfeeding, the ones that just kind of take a little bit at a time and then they fall asleep. So this is definitely something where they might just be fatiguing quickly. And I'm going to kick it to you, Colette, to see if you had any additional tips for those guys.
Yeah, snack and snoozers. I mean, in the very beginning, I let it ride, but these are babies who that's a first signal of problems associated with reflux. They like very small, frequent feedings instead of filling up because it's uncomfortable. It can also, I would look for a tongue tie in this place, because if you're stretching that muscle out and you just can't do it anymore, you may take smaller feedings and then give up and fall asleep, and then, have to do more frequent ones. And sometimes it's a sleepy baby, you gotta wake their butts up.
Yeah. Loud feeders. So Colette mentioned this on the last side too. So we don't want to be hearing that tongue clicking. Certainly during a feed as well. That usually indicates that something isn't quite right. Sometimes we hear a lot of gulps too, and that's not necessarily a great sign either. They might be having some difficulty with coordination, particularly if it's something you're noticing at each feeding. If it's just kind of here or there, they might just be getting a bigger gulp for that swallow. But if it's a pattern, it's definitely something to be looked at. Clamping down on mom's nipple. So this is something that could happen if that milk flow is a little bit faster than what the baby can handle. That definitely is not comfortable for mom. So as Colette said, we can kind of have mom, break that seal, and depending on the timing too, we might want to relatch, we might want to give that baby a little bit of a break. Refusing the breast and only drinking from a bottle. There are definitely babies like this who really, as Colette said, are preferring one method over the other. And if we look at it, a lot of times it's something anatomical that's different. So in addition to the tongue tie, often we see babies that have lip ties too. And a lip tie can really impact breastfeeding too, because the baby can't get that seal that they need and that suction that they need for a successful feed. So some of those babies that have a lip tie might be more successful with the bottle versus the breast, because that seal can kind of be a little bit more forgiving on the bottle versus the breast. Requiring maximum flow or cross-cut nipples. So this is a really big red flag for me as a speech therapist, because I tend to want those babies on the slowest flow nipple. I don't really want them to be increasing to a higher flow nipple, because that really puts them at risk for aspiration or for that milk going down into the air pipe instead of the food pipe. So we want to make sure that we're setting those babies up for success and have them start with those slower flow nipples. And really, they don't need to advance to a faster flow nipple. They might go from maybe a slow flow to a 1 or a 2, but really babies should not need a 3 or a 4, and that's kind of a concern for me, because we're really putting them more at risk for bigger problems. And if we have those babies where we're repositioning and those techniques aren't working, we definitely should be consulting with lactation consultants at that point, and then also touching base to see if there's something else going on, because those might be the babies that have something physical like torticollis, and we want to make sure we have all of our team members in there so that we're addressing all those needs. All right. Did I advance to the next slide? I can't see on my screen. I went dark.
Yes, you did.
Okay.
How to handle feeding struggles.
I'm back. Sorry about that. I think my battery got a little jumbled there. Okay, so now how to handle feeding struggles. So congestion or skin conditions. So a lot of times we'll see these in babies that are having some kind of allergic reaction. Same with that excessive drooling. Sometimes it can be an indication of some type of GI discomfort. Again, that drooling we really should not see in infants unless it is a phase at which they're getting new teeth. A lot of times that is really indicating something gastrointestinal, and we want to consult with the pediatrician to see if they want to make a referral out to GI or try some medication. Not exploring toys or not mouthing toys or exploring with their mouth. This is such an important stage in development. We want babies to have their hands in their mouth, and we want them to be placing toys up to their mouth as well. This is really what helps to push that gag reflex back in the mouth so that they're able to advance their feeding skills. It also really helps with speech development too, because they're learning how they can move their tongue around and how they can move their lips together. It's this great stage of exploration that really helps them develop those later skills. So when I see these young guys and a parent says that they really haven't put anything in their mouth, or they kind of skip that stage in development, that's definitely a concern for me and something we want to target in therapy. So a swallow study might be something that your physician might recommend if your child's having more difficulty with swallowing, or if we're seeing some indications that they might be aspirating on any foods. It can be a little bit of an intimidating test, but your physician would recommend it, if they think it's really necessary, and it can give us a good indication of where that breakdown is. It gives us a picture of what's happening, at after that food passes the base of the tongue. So we can see if there are any difficulties with, the throat. We really have like a lot of fine movements that have to happen to time that swallow and to make sure that everything's going where it should go in a timely manner. That's a great picture that gives us a good idea of exactly what's going on so we can treat it appropriately, and then also modify foods too. So there might be some foods that are safer based on the findings of that study. And then allergy and reflex testing, again, this is going to give us a nice picture of exactly what's going on so we can decrease the discomfort, which will then help the child advance. So, babies are smart. They know what they know when something hurts, and when they have that experience, they're going to avoid. So sometimes when we have a baby that's having allergic reaction to something, they might avoid all foods at that point because they just know that something that they ate has hurt their belly. So we want to make sure we can narrow that down and then safely introduce foods and increase that comfort. And it's important that these are identified early too. Otherwise, we have kids that we're seeing, later in development when they're toddlers or when they're even at that elementary school age that are still having difficulties with advancing foods. But all of these things can help guide what we're going to do medically. Again, feeding is just this huge, beautiful team project. Really, we have so many professionals involved, and it's so much fun as a therapist to just be able to talk it through with the lactation counselors, lactation consultants, and to also talk it through with the physicians and the other therapists on the team. All right. So activities that will benefit your baby. Routines are really important so that our babies kind of know what that expectation is, and it helps them to regulate their own behavior. Emotional development is very important. So we're using our face and our voice. We're using, gentle touch, appropriate touch, and motion so that our babies are getting used to that type of stimulation and having appropriate responses. Staying nearby when babies are lying or sitting close to each other. So this is just a general safety rule here. We want to make sure that we're not leaving babies unattended and making sure that everything around them is age appropriate too. Providing sensory stimulation, this is huge for development as well. So when we're introducing our babies to different sensory experiences, it's helping them to learn how to regulate their own bodies and adjust to those changes. All right, and then looking at the next slide, we have using simple and clear language to communicate. So we really want to be using our voice and our facial expressions to help emphasize the message. We want to be making sure that our tone reflects, whatever is appropriate in this situation. The next one is hard, but we have to make sure that we're using the word no sparingly. We don't want to be saying no to everything. We kind of want to save it for those situations where it's something that's really important to attend to. So we don't want to be saying no for every little thing. And then that tone is also really important. So when it's something that's really safety related, it needs to be that firm no, so the baby's really understanding that that's something that could potentially be dangerous. And we're going to have tears and we're going to have that big fat lip reaction, but that is good. That tells us that the baby understands that that's something to be fearful of. And then giving babies the opportunity to move around and be active throughout the day. So we kind of talked about that on the previous slide. And I know Jenna had mentioned it too, like we really want to be having our babies out of that car seat and out of the play seats and things like that. So they have the opportunities to move and explore their environment. Planning their day so there are no long waits between routines and experiences. So this is really important as well, just to make sure that we're not having those long pauses of inactivity, that they're kind of having those experiences throughout the day. Thinking about the situation from the child's perspective. So we want to make sure that we're kind of giving everyone the benefit of the doubt there and seeing what's happening. And we want to make sure that we're understanding the developmental level that they're on and responding appropriately. And the next one, again, is for our older guys, but making sure that we're giving those kids a chance, those older guys, a chance to work things out, particularly if it's something, a situation where there isn't harm. We want to see if they're able to kind of work that out on their own. very hard with siblings. I know I've got a house full here, but it's definitely super important to let them do that because it helps so much with their emotional development. And then we have just a resource here. If you wanted to click on it, it just has the developmental milestones for babies. And again, just make sure that you're consulting with your pediatrician if you have any concerns, and they'll point you in the right direction as well.
Thank you so much, Irene. Everyone, we'd like to thank you for joining us. Does anyone have any questions? Okay, don't see any coming through on the chat, but if you do have any questions later, you can always respond to the registration email that you got, and we'll be able to help you answer that. For anyone who is looking for Act 48 credits, if you go to the handout section right here, there's a form that needs to be filled out. I'll also be sending that out tomorrow with a copy of the video for everyone to review.
I have a question, if that's okay.
Of course.
So the drooling, when is that supposed to start? Because I see it often at like 3 or 4 months, but is it not supposed to start till later?
It kind of depends on what's happening, you know, oral motor wise for these guys. I would say, again, at that point, like right around the 3-month mark, when we're transitioning from more of the reflexes to the child being able to, you know, gain control over everything, we might see a small period of drooling there, but it really shouldn't persist. Yeah, so for those like 3 to 4 month olds, you might see a little bit, but we don't want that to then be something that carries over. It should kind of fade and then, you know, come back only when they're teething.
Got it. What is it a signal of if they're doing it early?
Oh, if they're doing it early, usually it's indicative of either like a low tone issue. And low tone for me, I'm even thinking more like GI low tone. So it might be something that's just kind of impacting their ability to manage things GI wise. And then really for those babies at that point, even if they had low tone throughout the mouth, they shouldn't have that saliva buildup unless there was something else kind of going on.
Okay, thank you.
Sure.
And any other questions?
Any other questions, Lauren?
Doesn't look like it.
Okay.
It's just me and Colette
Just
chatting.
wanna thank everyone. Thank our presenters and thank everyone for joining in. Please let us know if there's other topics that you would like to learn more about that we can bring to you. And again, if there's any other questions after the fact, please forward them to us through the registration, right, Lauren?
Right.
Yeah, so we hope everyone's staying safe and doing well. Enjoy your babies. It is just the best time of life, and we hope that all this information was helpful. And have a great night. Take care, everyone. Thank you.
Thank you. Bye-bye.
Thank you.